Now it's my turn. I will not introduce myself to talk on frontal fibrosing alopecia. In different parts of the world, people tend to cover the scalp in different ways. And some ladies would like to show just the starting of the hair. And if you suffer from this disease, you might not be able to properly cover that place. Let me start with a clinical case for you. This is a 50-year-old man who presented to our clinic with a frontal pattern hair loss. He referred that the disease started a few months before in apparently quite abrupt appearance, and he had no significant familial background. This is the aspect of the patient I'm showing to you. If we get close to the patient, we can see that we have four options. What do you think this patient is suffering from? Androgenetic alopecia, lichen rubor planus, vitiligo, frontal fibrosing alopecia, a mixture of frontal fibrosing and androgenetic alopecia, a mixture of lichen rubor planus and vitiligo, a mixture of all of them, some of them, just a couple of them. Let's get close to it, have a look to the aspects clinically, trying to find if you see any isolated hair follicles alone, or get closer in these aspects of vitiligo-like or vitiligo true. Have a look to the trichoscopy of the patient and then try to answer for yourself. What do you think the diagnosis on that patient is? But I will not give it now, and I will keep it for the end of my talk, if you don't mind. That's the plan of the following 12 minutes. I will try to discuss with you some aspects on frontal fibrosing alopecia, and I hope you agree the plan that I have put in here. So I'll start with terminology. We agreed because someone proposed, and it's not a Cossard, the guilty of that frontal fibrosing alopecia should be called frontal fibrosing alopecia. But in fact, from most of us, this is a peripheral fibrosing alopecia, because if you see, many of the patients keep with the area that goes beyond the ears. And if you see many patients, they go all around the scalp. So this is not frontal at all in many cases. I would like that we all together make a revolution and we change the name, that it's too much established now to be changed. But it would be nice to think it in another way. Peripheral fibrosing alopecia. What's the definition of this disease? Well, Cossard in 1994 described this new and peculiar type of hair loss that he named postmenopausal frontal fibrosing alopecia. So if we agreed that we change postmenopausal, why we have not agreed on changing frontal? This peculiar type of pattern hair loss usually affects the frontal line of the scalp with this band-like appearance, but not only the frontal line of the scalp. Usually the eyebrows are also affected, and in most cases, histology shows a lichenoid pattern. But usually there are no clinical signs of lichen planus on the rest of the body. Most of the patients are females, most of them are white, most of them are postmenopausal. About 3/4 of them show eyebrows loss, and some of them complain of a scalp pruritus, and we see this perifollicular erythema, which is part of the treatment, important follow-up that we try to see. Clinical images of patients, you all know the clinical images. This is not a difficult diagnosis in most cases. This expression of the frontal veins, it's also a very typical aspect. This is a case of a Sturge-Weber patient that she developed a frontal fibrosing alopecia, and it was surprising to see how the hairs were affected on the area of the vascular anomaly was covering before, so she was even more complaining of that problem. There are many associations of this disease that we don't know if they are causal or not. In this paper from Mariva Miteva in 2011, she describes the group of Tosti, this association with vitiligo. And they state on that paper that changes in color in the scalp appearing in these patients are not necessarily post-inflammatory hypopigmentation. We see many patients with changing of the color of the skin on the areas affected by frontal fibrosing alopecia. Sometimes we believe that this is because the hair was covering that part of the skin, so the skin was not sun damaged. But in some cases, the skin is too white to be just protected by the sun. Some of you might think that the association of vitiligo and frontal fibrosing is the same pathogenic mechanism, or maybe it's part of the disease that the lymphocytic infiltrate, it's not only destroying the hair follicle, but might also be destroying some of the melanocytes. What about the pathogenesis? This is not an easy chapter. Well, the cause of frontal fibrosing alopecia is totally unknown, but there are many hypotheses. One of it is the decreased estrogen levels, or the allergic contact dermatitis, some external factors, genetic factors, or some cosmetic surgical procedures seem that in some cases might be inducing the onset of frontal fibrosing alopecia. What about estrogen levels? Well, the French literature reported 3 children with frontal fibrosing alopecia, so obviously not in all cases. This is the idea, no? Estrogen levels and cosmetic surgical procedures might not be the only determinants if we see patients that are males or the patients that are children and so on. And this would be the answer to most of the questions. What about the cobalt chloride hexahydrate? This is a metal found in various products, including facial skincare products, and this was the most frequent allergen found in a multi-center study by Lydia Rudnicka et al. In 2020. What about the sunscreen? There are many articles also trying to find a relation between the use of sun blockers and the onset of frontal fibrosing alopecia. There are many studies trying to evaluate that, but this is insufficient data to currently support these associations, and we have patients in different parts of the world that are not using at all sunscreen, and they are also developing the disease. So it might be triggering the disease in some patients and not in others. What about the leave-on cosmetics? They have also been investigated, and this article from a Brazilian group in 2010, they found that patients with frontal fibrosing alopecia used twice as many facial sunscreens as controls, and the majority of them tested positive to fragrances on patch test, particularly linalool hydroperoxide and balsam of Peru. So from this article, you could think that because they use it twice as the others, this could be a cause, but it's not in all cases. So from this other article, they found that the link between frontal fibrosing alopecia and the use of face leave-on cosmetics is still debated and not confirmed in other studies. So we all have some studies that point to a direction and other studies that show that the direction is not conclusive. What about the titanium? A scanning electron microscope and energy dispersive X-ray spectroscopy showed that hairs extracted from patients with frontal fibrosing alopecia had 8 times higher concentration of titanium-containing nanoparticles compared with controls. And they know that titanium-containing nanoparticles might be highly reactive and able to generate free radicals with UV radiation. And this was published in the Blue Journal a couple of years ago. So it looked like we were on the right direction. But all the sunscreen protectors without titanium has been also related to frontal fibrosing alopecia. So probably this is not the case for all the patients we are seeing. What about these facial moisturizers and occupational exposures that are also under suspect? It may be plausible that this article, a very recent article, showed that we are seeing younger and younger patients with frontal fibrosing alopecia. It is plausible that younger patients are also presenting now to us with this disease because of early exposure to more external insults. There's this also article from Ramirez Marin and Tosti that they try to explain that the collapse of the hair follicle immune privilege might be related to the onset of frontal fibrosing alopecia. And they state that this association might be relevant because women tend to have higher frequency of autoimmune disorders, and this would be the idea. We have still to work on that to see if it's the case or not. Let's move into treatment that most of you are more interested probably than not on pathogenesis. Even as being dermatologists, we all like to understand what are the diseases we're seeing, and frontal fibrosing alopecia, it's a disease that we do not understand. Currently, unfortunately, there are no evidence-based studies to guide treatment for patients with frontal fibrosing alopecia. So we will have the same final conclusion. Some articles show good, relevant results, and others show that these results were not conclusive. Hydroxychloroquine, doxycycline, mycophenolate mofetil have been reported to be useful in some patients, but not in others. Potent steroids might be useful for decreasing inflammation, applied topically or injected or orally, but variable results when studies are performed in large populations. This is a recent article. They try to find the differences between combining oral isotretinoin and topical tacrolimus versus oral finasteride and topical tacrolimus. This is a well-performed study, and they found this conclusion. Although both work, they found more effective the association of tricholimers with isotretinoin. This is an interesting article from the Australian group on trying to review the frontal fibrosing alopecia options. And from the group of Rod Sinclair, they state that retinoids, including isotretinoin, using 20 or 40 milligrams daily, have not consistently been shown to be effective in frontal fibrosing alopecia, even if most of us would like to use it. And it seems that in some patients help also on the facial papules that we've seen associated with this disease. From the same article, antibiotics like tetracycline has been used for their anti-inflammatory effects, often after anti-malaria failure, so not also anti-malaria's work, and the responses rates are also very variable. What about immunosuppressors and immunomodulators? Oral methotrexate, cyclosporin, mycophenolate mofetil, azathioprine, and rituximab has been used with controversial results. This is also an article trying to discuss the efficacy of the anti-malarial drugs in these forms of frontal fibrosing alopecia, and they state that the results of the statistical test do not confirm the existence of a relation between the age range and treatment efficacy on the use of hydroxychloroquine. This is a German article from the group from the Charité Berlin, from Ulrike Blume-Peterwe. It's an interesting article, a very recent one also, and they have some interesting conclusions from that article. And Ulrike states that currently therapeutical management largely relies on anti-inflammatory options, combined topical, interlesional, and systemic depending on the disease activity. But the chronic progressive course, sometimes even in the absence of pronounced inflammation, remains a challenge. Controlled studies are still required to develop evidence-based recommendations. This is an algorithm proposal for hair transplantation. If you don't allow to stop the disease, some doctors like to do hair transplantation on frontal fibrosing alopecia, and most of us would probably not agree on that. And this is probably the less harmful idea. If you tell your patients to avoid sunscreen, this might be helpful. Despite these limitations, the results highlight the significant association between sunscreen moisturizers and frontal fibrosing alopecia. So I'll arrive to the conclusion saying that this disease does not only affect postmenopausal women, it's a psychologically devastating disease. We do not know the cause. We do not know the best treatment for it. The group of Alice Olsen last year performed an excellent review, and we helped her trying to be part of the team. Many of the people sitting here are involved on that article, and this might help us on better understanding in the future what are the guidelines for the clinical trials to be properly performed in order that the results we get are useful to tell if this is working or it is not. Let's get back to that patient. What do you think that patient had? Anyone would like to comment? Let's have a look again to the trichoscopy. No one? Well, I think he had a mixture of the four of them. And even if Cossard described in 2002 the first cases of frontal fibrosing in a male, we've seen plenty of them affecting the beard. And if anyone ever tells you if you'd like to have an elephant shower, be careful because you might be seated on an elephant and you might get all the shower on your face and then you have to get out of it. But if never anyone invite you to Barcelona, accept it because you might have a party there and you might also have the chance to attend to a nice meeting. So if you'd like to join us, we're having a hair meeting at the end of the month in Sitges, a beautiful place in Barcelona. I invite you all to come there, barcelonahair.org. There are still some places for you to join. Thank you very much for your time. Do we have any burning questions? Yes, please, Jerry. Do you want to come here?
What do you think of the excimer laser for this at 308 nanometers? I've been using it, and we're getting some results. I think it works in some people. So I think it's another option in our armamentarium is light therapy with the 308 nanometer laser.
Okay, thank you. Thank you for the comment. I've read some articles on the excimer laser, and the results are really promising, but I think that the same as the other articles, they do not work in all patients, but in some of them you get results. Totally agree with you. Thank you. Yes, Anna.
Thank you very much. Congratulations on the excellent lecture. I would like to ask, what is your favorite treatment for frontal fibrosing alopecia?
I know someone would like to do that. I think it's not really relevant what I do because I'm not able to cure my patients. So I think most of us, what we do is we add some anti-androgens because in most of the cases, like that patient I showed to you, they have a mixture and it's the same area affected. So I think using anti-androgens helps a little bit on having better results. Oral minoxidil, topical steroids, and sometimes I use also anti-malarials. even if the results on the literature are not so conclusive. My feeling is that I'm doing something to my patients, but I'm not sure if it's the right thing to do. But maybe in the future we'll be able to answer it more scientifically. Anyone else would like to comment? No? If not, I think we'll have to ask the organization to give us the chance to see the next presentation from Professor Tos.